pregnancy. Share with all your relatives who are pregnancy who are going through pregnancy, so they know what's normal and what's abnormal. So cutaneous changes, which happens due to estrogen in pregnancy and increased melanocyte stimulating hormone MSH. Linea nigra, Xiphisternium pubic symphysis, darkly pigmented type. Snail trail, stretch marks, pink stria gravidarum, stretch marks of current pregnancy. Silverish stria albicans, stretch mark of previous pregnancy, and pink is current pregnancy. Pregnancy mask, chloesma gravidarum, pigmentation of the face. Palmar erythema, redness on palms. Spider navy, dilated veins below skin. Changes in reproductive organs. Uterus, weight of uterus up to 1.1 kg due to hypertrophy. Main cause hyperplasia in trimester 1 only. Hormone responsible progesterone. Increased uterine flow, increased uteroplacental blood flow, 500 to 750 milliliter per minute. Uterus is dextro-rotated to right side to accumulate sigmoid colon. Breast growth ductal due to estrogen, alveolar due to estrogen plus progesterone, fat deposit due to insulin. Colostrum, yellow discharge expressed by 12 weeks of pregnancy, Montgomery tubercles. Cervix, Chadwick sign, Jacquemin sign, bluish discoloration of cervix. Mouth of cervix closed by mucus plug. Purpose, prevent ascent of infections, release of show, blood plus mucus expelled in true labor pain. Hypertrophy and hyperplasia of cervix, length of cervix is 4 to 5 centimeters. Ectropion, eversion of cervix, columnar epithelium of endocervix grows over, squamous epithelium of exocervix presents as postcoital bleeding, non-premalignant, no biopsy needed. Endocervix, exocervix, cervix in per speculum examination. Vagina, lactobacilli, Dorderlin bacilli, increased conversion of glycogen to lactogen, decreased pH acidic 3.5 in vagina in pregnancy, decreased pathogenic bacteria. Most common vaginitis in pregnancy, candidiasis, also known as candida, can survive in acidic pH. Bluish discoloration, Chadwick-Jacquemin sign. Endocrine changes. Pregnancy is a progesterone dependent condition. Progesterone suspension of ovulation, increase estrogen and progesterone from placenta, negative feedback, decrease luteinizing hormone and follicle stimulating hormone, ovulation suspending in pregnancy. Amenorrhea, increased progesterone supports decidua. Amenorrhea in pregnancy. Estrogen is increased estrogen dependent changes in pregnancy. Skin changes, increased thyroid binding globulin, obstetric cholestasis, fluid retention, onset of labor. Prolactin, released by pituitary gland plus decidua. Levels during pregnancy in third trimester are more than during lactation. Increased estrogen inhibits action of prolactin. No milk produced in pregnancy. After delivery, placenta delivered. Decreased estrogen, first stimulation of lactation, inhibitory effect on prolactin and milk production. General changes. BMR, basic metabolic rate, increases by 10 to 20% as pregnancy is an anabolic state. Physiological edema causes retention of fluid 6.5 liters. Sodium and potassium retention. Concentration of sodium and potassium decreases due to dilutional effect. Plasma osmolality. Viscosity decreases due to fluid retention. Pressure of uterus on inferior vena cava. Hypoproteinemia, physiological versus pathological edema. Physiological edema on rest subsides, pathological edema does not subside. Pitting present, physiological, absent, pathological. Sites, dependent parts, feet on standing, sacrum on lying down. Pathological, non-dependent parts, above knee, anasarca. Management, no required reassurance and rest. Required for pregnancy-induced hypertension. Hematological changes, parameters, plasma volume increases. what all increases? So plasma volume increases, blood volume increases by almost 50%, RBC volume increases by almost 30%, hemoglobin mass increases, O2 carrying capacity of blood increases, erythropoietin increases, reticulocyte increases due to erythropoiesis, mean corpuscular volume increases, WBC count increases more than equal to 15,000 pregnancy, more than equal to 25,000 in labor, neutrophils are seen, all inflammatory protein increases like CRP, ESR, clotting factors increases excluding number 11 and 13, hypercoagulable state is a pregnancy, pregnancy is a hypercoagulable state, plasma protein mass in grams, globulin increases, sex hormone binding globulin, thyroglobulin. What all decreases? Blood viscosity decreases due to hemodilation, hematocrit decreases due to more increase in plasma volume than RBC volume, HB concentration does not fall below 11 gram per deciliters, RBC lifespan decreases, platelet count doesn't decrease below normal range called benign gestational thrombocytopenia, clotting factor 11 and 13 decreases, all other clotting factor increases, fibrinolytic activity, protein C, protein S, antithrombin levels decreases, plasma protein concentration decreases because albumin decreases, Ag ratio is equal to 1:1. Hemodilution and pregnancy, compensatory mechanism, increase cardiac output, increase 2-3 bpg, right shift of HbO2 dissociation curve, increase SpO2, decrease blood viscosity, parameters which remain unchanged, bleeding time, clotting time, APTT, mean corpuscular hemoglobin concentration, pH of blood. Note, isolated increase in APTT plus history of thrombosis in any individual, Apla syndrome. Renal changes. Size of kidney changes and increases by 1 centimeter. Bilateral hydroureter causes increased progesterone, smooth muscle relaxin, decreased peristalsis in ureter, urinary stasis. Risk of leads to increased of risk of UTI, right in more than left due to dextro rotation of uterus to the right, increased pressure on the right side. Renal blood flow increases 80%, GFR increases 50%, increased filtering capacity, serum urea, serum uric acid, serum creatinine. Urinary frequency increases in trimester 1 and trimester 2, causes in trimester 1 irritation of bladder by growing uterus in pelvis, relieved in trimester 2 uterus becomes an abdominal organ, in trimester 3 due to descent of fetal head into the pelvis, bladder pressure increases, increased risk of stress urinary incontinence. Changes in urine routine microscopy done at first antenatal visit. Glycosuria positive, rule out diabetes. If negative, physiological glycosuria due to decreased renal threshold for glucose. Proteinuria not physiological, seen in pregnancy induced hypertension. Asymptomatic bacteria more than equal to 10⁵ bacteria per ml of midstream clean catch sample plus no UTI symptoms is asymptomatic bacteria. Most common organism is E. coli. Urine routine microscopy repeated every trimester to monitor asymptomatic bacteria. Complication preterm labor, acute pyelonephritis 25% cases, risk factors diabetes and sickle cell anemia, management is nitrofurantoin drug of choice, reoccurrence rate is 30%. Gastrointestinal system changes, motility changes, increased progesterone, smooth muscle relaxation, increased risk of GERD, increased risk of constipation, decreased gallbladder contractibility, increased risk of gallstones, gastric emptying time normal in pregnancy, increased during labors, clear fluids recommended, solid foods to be avoided, hepatic enzyme increase alpha fetoprotein due to release from placenta, heat stable alpha fetoprotein, and released from liver. SGOT and SPT normal, elevation always pathological, for example HELP syndrome. Respiratory changes, anatomical changes. 2. Transverse diameter of chest increases by 2 cm. So the mnemonic is 246. Transverse diameter of chest increased by 2 centimeters. 4. Diaphragm is pushed up by 4 centimeters. 6. Chest circumference is increased by 6 centimeters. Subcostal angle increases. Increase inspiratory capacity, tidal volume, minute ventilation, carbon dioxide washout, respiratory alkalosis, increase SpO2, decrease SpCO2, compensated by renal bicarb excretion to maintain normal pH, constant inspiratory reserve volume, respiratory rate, vital capacity, decreased total lung capacity, residual volume, expiratory reserve volume. Other changes: O2 related parameters, or increase O2 carrying capacity, O2 binding capacity, O2 demand, SpO2, decrease arteriovenous O2 gradient, iron metabolism. All parameters are reduced except serum transferrin and total iron binding capacity. Calcium metabolism. Fetal requirement is 30 mg for fetal skeleton formation. RDA in pregnancy for calcium is 1000 mg per day, started in trimester 2. Vitamin D 400 international unit per day. Increased GI absorption of calcium, active form of vitamin D. Decreased bound calcium due to decreased albumin. Total calcium due to decreased total calcium due to increased fetal uptake. Normal unionized serum calcium. Minimum duration between iron and calcium tablet is 2 hours. Pituitary gland size increases by 125%, mainly anterior pituitary, increased blood flow. If decreased blood flow due to pituitary hormone, Sheehan syndrome,